So let me begin and talk about the treatment. And I want to, just first some disclosures, same disclosures. And I want to just mention at the outset that all I will be talking about is on the treatment on the cardiovascular aspects of the postural tachycardia syndrome. So not going to focus on many of the multi-system aspects of the syndrome that Chris just touched on, and this is going to be a continuation of Chris's talk. And a couple of points to make at the outset, that there are no FDA-approved treatments for the postural tachycardia syndrome. And that's possibly the most interesting and the most unfortunate aspect of this. And there are no long-term good randomized placebo-controlled clinical trials. When we think of therapeutic interventions, we need to think of interventions to treat the orthostatic intolerance, and those that we have at this point are in large part based on what we know about the treatment for neurogenic orthostatic hypotension, of which there are a number of treatments, both FDA approved and some pretty good long-term randomized placebo-controlled trials. And then what we want are treatments to treat those unique features of the postural tachycardia syndrome, and this is where things are really lacking. But point made by Chris, which I will emphasize, the optimal management is really comprehensive and multimodal, and the elephant analogy is a really good one. You've got to look at the disease in its entirety, and again, first-line treatment of postural tachycardia syndrome and every disease is non-pharmacological first. If you can avoid using medications, it's so much better. So I spoke earlier about the problem, and this is the problem, that pooling of 20% of our intravascular blood volume, and here you see it happening over time. And as you see, we go from a very nice central intravascular volume to less and less with time. And this is a normal physiological phenomenon. And the miracle I mentioned earlier, the miracle that we're actually able to remain standing, and that really is a miracle. So let's begin to talk about the treatment overview. And the treatment overview is, of course, education and its prevention and its reversal of whatever deconditioning occurs. And I think Chris elucidated very nicely that deconditioning is a part of every medical illness, and that whether it is a primary or secondary phenomenon, that you need to reverse it. It may be that the postural tachycardia syndrome was caused post-viral, or due to Ehlers-Danlos loss, or due to a genetic defect, or due to some immune-mediated disorder. No matter what the cause is, reconditioning is a part of the treatment. And then there is pharmacotherapy, and again, I'm focusing on the orthostatic intolerance aspects of it, and we are increasing the intravascular volume, and we are vasoconstricting. So if you think back to that picture, we are trying to bring the blood back into the intravascular compartment, and we are trying to vasoconstrict. Now, Chris and I didn't plan this in advance, but in his water drinking, he left out something, and I was going to slip over the slide if he touched on it, but there's something important to know. We know from the treatment of orthostatic hypotension that rapid ingestion of 500 cc's of water raises the blood pressure. So if you rapidly ingest 2 of those little Poland Spring bottles of water, or 2 of those glasses that you see over here in the front row, and do it really rapidly like the college kids do, this will raise your blood pressure. And I have suggested this in many patients with postural tachycardia, even though they are not good data, and people have reported that this provides symptomatic relief. Now, this is not gradually sipping, like you're having a cocktail on the beach. This is glugging it down really quickly within minutes, and this raises the blood pressure. It's an emergency procedure, and the underlying physiology has actually been really nicely worked out, and it really does activate the sympathetic nervous system, and it probably is a reflex which involves the blood pressure, the blood vessels close to the liver. But the point to be made about it is this is not distilled water, this is not Gatorade, this is not Diet Coke. This is tap water. You have to drink tap water. And of course, it's not whatever, college kids drink, tequila or margaritas. This is tap water. Okay, so what are we going to do? We are going to increase central blood volume and going to enhance vasoconstriction. And how do we pharmacologically increase intravascular volume? By using the mineralocorticoid Fludrocortisone. This is a stripped down steroid. It doesn't have any of the consequences of taking glucocorticoids or steroids that the baseball players and weightlifters and tennis players take. This is stripped down. It increases intravascular volume, but as I'll say in a second, it's not without complications. So this does increase intravascular volume, but it also has some downstream consequences. So the Fludrocortisone is the first line, and then we have a variety of other medications that I'm going to talk about. So how does Fludrocortisone work? Well, its main effect is by increasing the intravascular volume, but it has some other secondary effects as well, and maybe a more complex mechanism that involves the autonomic nervous system. We used to use large doses, 0.2, 0.3, 0.4, even up to 1 gram. But over the past couple of years, it's become really apparent that this is not a benign medication. It's not just that it may raise the blood pressure in supine, cause edema and congestive heart failure, but long-term use is probably bad for the heart. There's preclinical evidence that the agonism of the mineralocorticoid receptor can cause cardiac fibrosis if it occurs with long-term use. And so we are using very, very small doses these days, sometimes just half of a tablet 3 times a week. So the trend is away from using this drug and much more in the direction of using a fluid and salt if we can possibly do it. The next approach is to understand that orthostatic hypotension is in large part a problem of the sympathetic nervous system, and noradrenaline, norepinephrine is the primary neurotransmitter, and the more that we can get norepinephrine to hit the postganglionic receptor, the neurovascular junction, the more likely we are to be able to raise blood pressure. Now, in the postural tachycardia, this has become a little bit more complicated in ways that we don't quite understand, but I'll talk about that in a second. What we do know is that if you can hit the alpha-1 adrenoreceptor, which is the receptor on the blood vessels that results in vasoconstriction, if you can hit it directly, that helps. And it also appears that if you can increase the amount of traffic in the postganglionic neuron, and I'll talk about this in detail, I just want to introduce it now, it also helps. I'll clarify the gray in just a second. So now we are talking about directly hitting the receptor. So this is the receptor that is on this blood vessel over here that is agonized typically by norepinephrine and results in vasoconstriction. And I do need to acknowledge Ben, who drew a beautiful figure for me. Okay, so this is a vasoconstrictor. It's a prodrug that's converted to a drug which is the active drug. It doesn't cross the blood-brain barrier, so there's no tremulousness, there's no jitteriness, and this is unlike medications like phenylephrine or ephedrine, which do cross the blood-brain barrier and do cause jitteriness. The peak effect occurs in 1 hour. It lasts for about 4 hours. There's quite a bit of interpatient variability, and these are the kind of doses that we use, between 0.25 to 10 milligrams, sometimes even more in patients who have neurogenic orthostatic hypotension, but rarely in patients with postural tachycardia syndrome, and we'll use it 3 or even 4 times a day. Side effects, as you see below, can raise the blood pressure, may cause piloerection. piloerection, what's that? Hair standing on end, typically on the scalp. And really what you're doing, why this happens, is that you are really stimulating the sympathetic response, the fight or flight response, and you are causing patients to have their hair stand on end, just as if they saw something extremely frightening. And it's not a surprising side effect. Patients often experience this as itching. It's not an allergic reaction. It's not an anaphylactic shock. It really is just hair standing on end, activation of the piloerector muscles. Now, what about POTS? What do we know about POTS? Well, there are a series of studies. Now, all of these are short-term studies, or they're based on tilt table as a surrogate, as a model for POTS. None of these are long-term studies out in the community, but all of them have suggested that there is an effect. One that you see at the bottom that I want to just mention very briefly suggested, and these, unfortunately, there are very, very few studies. And so I think there is a danger in inferring too much from the limited literature that's available. And the message is that we need more and better studies, and we need longer-term studies. But in this one study, the Midodrine was effective in neuropathic POTS, so where the nerve was gone, but in hyperadrenergic POTS, and this is, again, a heterogeneous disorder, but that in which there was sympathetic overactivity, it was not effective. I think take this as a single study in a single center, and when you are treating patients, be mindful that it may well work in that particular patient in front of you, and I would not avoid using this drug if it were necessary, even in a patient who has some kind of sympathetic hyperactivity. What else? Well, there are medications that can increase nerve traffic in the postganglionic neuron that you see over here. And one of them makes acetylcholine, which is the neurotransmitter that is available in the autonomic ganglia. And if you make more acetylcholine available, then you are going to increase more activity and result in the long run in somewhat more norepinephrine release. And this has been used. It has a modest effect in neurogenic orthostatic hypotension. We, by inference, have attempted to use this in patients who have the postural tachycardia. And the way we induce this mechanism is by inhibiting the breakdown of acetylcholine in the autonomic ganglia. And we use a medication that's widely used in a number of different ways called pyridostigmine. The trade name is Mestinon. It's most widely known as a treatment for myasthenia gravis. But pyridostigmine is an acetylcholinesterase inhibitor. So it inhibits the enzyme that breaks down acetylcholine, so there's more of it available, and increases neurotransmission. So, being two trials, both are very, very limited. One was just a tilt table study, and the other was one which was used as an outpatient study, but the drug was poorly tolerated. And this is not a well-tolerated drug. Many patients will have what we think of as muscarinic activity, salivation, sweating, gastrointestinal cramps. But in some patients, particularly in the low doses that have been used, it may be of benefit. What about other medications? Well, unique to POTS is the use of beta blockers, adrenoreceptor blockade, regarded as a third-line therapy for very complicated neurophysiological, neuropharmacological reasons in patients who have orthostatic hypotension. And there are data that this may help in POTS patients. We have a certain attitude as to when it's used and why it's used. And I'll talk a little bit about that in a second. And then finally, and I'm not going to talk much more about this, central sympatholytic agents. So agents which decrease sympathetic outflow, and these include tranquilizers and sedatives, but also medications like clonidine. And the data over here are quite equivocal, and the data are not particularly good. I do want to talk about beta blockade. And obviously, when you give a beta blocker, you are blocking the autonomic nervous system, and in particular, you are blocking the increase in heart rate that occurs. Now, and there are some data. Data suggests that perhaps low dose, so 20 milligrams, which is a very low dose of propranolol, may decrease the tachycardia and improve the symptoms. But higher doses, 80, did not. Very, very short surrogate model studies. And then in another study from the same group, they looked not only at the beta blocker propranolol, but they extended it to a more selective beta blocker, the Beta-adrenoreceptor blocker, metoprolol, low-pressor. Propranolol is a non-selective, acts on beta-1 and beta-2 receptors, and they show that metoprolol did not do it, and high-dose propranolol also was not helpful. Now, we have not studied this formally. I can say my clinical impression is that you want to try and work out when the heart rate increase is actually compensatory, when it is a force for good, when it is maintaining orthostatic tolerance, and you want to work out when it is getting in the way of things, when it is resulting in an awareness of palpitations, a feeling of disease, when the autonomic nervous system is functioning in a disinhibited way and the increase in heart rate has no relationship to controlling a problem with intravascular volume or vasoconstriction. It's not so easy, but we try to do that in a way so that we know when to use beta blockers, and very early in the course, I will very rarely use beta blockers to treat postural tachycardia syndrome. I want to also talk about reuptake inhibition. Reuptake inhibition with SSRIs, selective serotonin reuptake inhibition, and the bottom line is that there is no evidence that they work to treat the cardiovascular aspects of the postural tachycardia syndrome. These are, of course, as you know, antidepressants, and sertraline is one of the widely used antidepressants studied. We have no idea really whether other antidepressants, other serotonin reuptake inhibitors don't work, but the data at this point suggests that they don't help the autonomic features, which is not to say that if a patient who has postural tachycardia and is depressed, you should not use these drugs, but don't use them to help the autonomic features, or at least there are no data at this point that they work. In contrast to that, the other group of antidepressants, the norepinephrine reuptake inhibitors, may make it worse. And there's an element of paradox over here, because you're increasing the availability of norepinephrine by using these drugs. And it appears that at least one study in atomoxetine and in other studies using selective norepinephrine reuptake inhibitors, it almost models the postural tachycardia syndrome. So I think this, to me, is somewhat of a paradox. It likely is due to the fact that there may be some heterogeneity in patients who have the postural tachycardia syndrome, and we haven't quite worked out whether there are patients in whom this class of drugs work and there are patients in whom it doesn't, and this is yet another example of more that needs to be done. I want to mention what should not be done, and these are interventions for which there's no evidence of effectiveness, there are no controlled studies, and are potentially dangerous, and the risks far outweigh the benefits, if there are any at all. And this includes radiofrequency sinus mode. I wrote mode, or my computer took over and wrote mode, node modification, decompression of the cerebellar tonsils, and jugular venoplasty and endovascular treatments. And here you see the references showing that these are disorders that should not, under normal circumstances, be regarded, these are interventions which should not, as under normal circumstances, be regarded as interventions that are appropriate for the postural tachycardia syndrome and should not be performed without seeing somebody who is a true expert in the disease. So, in summary, we need long-term randomized placebo-controlled clinical trials. We need to phenotype the patients. We need to understand the heterogeneity heterogeneous nature of the disorder so that we can decide which drug works for which patient much better. This requires a lot of work. At this point, optimal management, it's multimodal, multidisciplinary. The first-line treatment, as Chris Gibbons implied, is non-pharmacological, and we have some preliminary support for pharmacological interventions and avoid unproven surgical interventions. Thank you.